Hello, I would like to say a hearty welcome to everybody who are visiting my present lecture. My name is Tamás Divinyi. I am professor at the Clinic for Oral Maxillofacial Surgery, Semmelweis University in Budapest. My topic is a very popular one, which is demonstrated by the several books published in a relative short period of time. In my lecture, I would discuss some aspects of the theme which perhaps would be useful for the everyday dental implant practice. All the literatures are emphasizing how important is the mouth, the teeth in the whole appearance of the face. The answer to the question, what the aesthetic mean, they all emphasizing the importance on the individual character, the importance of the harmony, which suits to the patient, you see, and his or her individual appearance and character and is aesthetic and harmonious. The answer to the question is the same, which is emphasizing what the aesthetic mean, and always we can say that the aesthetic implant therapy has become an integral part of the modern dentistry. Dear colleagues, we have a wonderful tool in our hands, the dental implants. The high success rate in the anterior dentition means that we can answer to the high expectation on the aesthetics. Of course, we have to know our limits as well, on the base of the thorough examinations. The dental aesthetic means all the anatomic components resulting in a harmony. So teeth, periodontium, shade, form, symmetry, and all together will form the harmony of the face. The smile. The smile is very human. The animals don't smile. The smile is wonderful tool for the expressing emotional state, but very useful in the personal communication as well. Some authors try to make a classification of the smile, for instance, on emotions. A social smile, for instance, in enjoyment smile, or the appearance of the gum and the teeth. Solely maxillary smile, maxillary with 3 mm display. I will mention something about this topic. Maxillary mandibulary and solely mandibular smile. The factors determining the aesthetic value of the implant therapy. There are surgical and prosthetic factors determining, of course, the aesthetic value of our implant therapy. The surgical stage as follows: the patient evaluation, diagnostic, implant placement, the soft tissue management. We have to start with a very careful examination. The patient examination and the diagnostic is essential for completing a good aesthetic result. So, and together we have to consider there's the anatomic parts of the face, and also our investigation. It means also a risk assessment. But from aesthetic point of view, the risk assessment is very important, where we have to decide whether we can fulfill the occasionally very high expectation of our patients. The determination of the smile line. How much is visible from the teeth and the periodontium during smiling? It seems to be an easy job, but sometimes it is not. Particularly at young persons, may develop an inhibition in order to conceal the edentulousness. They probably won't give us a loose smile. And then is the determination of the smile. It is mean just, well, is important, and also in some cases there is an excessive gingival discray over 3 mm. It can be aesthetically displeasing. This is the so-called gummy smile. Is a high aesthetic risk. In an old case, I would just show to you where the metallic rim of the screw-retained prosthesis is visible, but the short upper lip, the low smile line, will cover it. The gingival outline follows some patterns, which should be taken into consideration at the placement of implant in the vertical plane. This pattern as follows. The straight pattern is characteristic of the middle-aged or elderly peoples, where the highest peak of the gingiva at the front teeth are in the same level. So the sinuous pattern is of the young individual's appearance. The differences but should not exceed the 2 mm. In this case, if it's over the 2 mm, it would be aesthetically unpleasing. It's particularly important as the neighboring teeth. If the neighboring teeth, the differences, it aesthetically can be very unexpected. So, for instance, you can see that this slide, then if in the vertical plane, we place not correctly the implant, the difference, the gingival outline at the neighboring teeth is visible. So, however, the contralateral side, it is acceptable. Any differences, it is acceptable. So, the differentiation of the periodontium biotypes is essential for the mucogingival surgery. So, the different types, the one is the thick flat periodontium, has a characteristic surface. The bulging of the alveolar process is not visible. It's a flat surface, and just the form of the teeth is also characteristic. This sort of periodontium is not inclined to recession, but also inclined a higher degree of scare formation after the suturing. So the other type is the so-called thin scalloped periodontium. This thin scalloped is aesthetically more pleasing form. The majority of the population belongs to this group. It's inclined to the recession and a low degree of the scar formation. It can be a very, very bad situation, the recession, because then the thin scallop type is often together with a thin marginal bone, and the gingival recession can be an aesthetic failure. Also, we have to mention the metallic color of the titanium implant, which may be visible through the thin mucosa. The morphological difference is the thin connective tissue layer lays under the mucosa. You can see the two pictures. The one is the thin scallop, the other is the thick flat one, and that is a slight difference. It is just the presence of the connective tissue layer. The most surgical part is the meticulous implant placement. In the vertical plane, the ideal position of the dental implant. The pictures show the correct implant position in the vertical plane. The ideal position of dental implant in the horizontal plane. Thus you see that the distance, the recommended distance from the neighboring tooth, and also the recommended distance between the different implants. So, which is biologically very important, is as a special entity of the oral implants. Namely, this is the biologic width. It's also called the gingival seal, biological seal, which is one of the important keys for the longevity of the oral implants. So then the morphology as follows. The From the upper part is the junctional epithelium, provide the defense of the defense mechanism for the peri-implant tissues. Then below in the basal lamina, part of the junctional epithelium adheres to the implant surface by numerous hemidesmosomes. And also this is an important, as a unique part, is a connective tissue seal, collagen fibers running a course parallel, mostly the machine surface, or directed on the basis of some opinions toward the implant surface perpendicularly. It is particularly at the macro texture surfaces. It provides the stability of the peri-implant mucosa. So the average value of the biology width had been measured on cadavers and had been found around 3 millimeters. Then at the placement of implant, the biologic width is to be considered to achieve the same gingival outline that of the neighboring tooth. The average is the 3 millimeter from the CEJ of the neighboring tooth. It depends on the thickness of the gingiva. And the vertical position, the schematic illustration on the X-ray, but the flapless approach is a practical method using the fixture driver as a measuring tool. You see, these are the marks on the fixture driver, and just we can measure the 3 millimeters, and even the rim to the rim of the gingiva, we can measure if the depth of the implant placement. So then, if your desk can be different, if there's an improper vertical placement, but you see that these pictures, then the low smile, the lower lip may cover it. Then the orovestibular position of the dentary implants, the picture shows the optimal placement of the occlusal plane. The picture shows the result of the improper placement. The position is too far palatally. In this case, then the too far palatally, the implant placement biased toward the palatal side, the prosthetic must be fabricated in a ridge lap shape. No, it is a problem, a big problem, namely the orovestibular width of the alveolar process. It decreases by 50% in the first 12 months following the tooth extraction. That's is by some authors. And also the resorption of the alveolar process after tooth loss influences our surgical plan. So, and it is also interesting that most of the orovestibular atrophy of the alveolar process happens in the first 3 to 4 months. And then in the surgically, the thin labial bone may resorb first. Now, what can we do? Our plan can be a socket preservation or immediate implantation. The socket preservation, there are several methods. The one as well known is a biocold technique by bone. Well, there is the placement of the bone substitute covering a resorptive collagen membrane. And of course, then this biocold technique, the ridge preservation technique, will not shorten the overall treatment time. The immediate implant, as the contrary, will do it. The immediate implant is then we name the immediate implantation at the same time of the tooth removal or the tooth loss. Well, there are certain advantages at the immediate implant placement. Of course, the less surgical intervention, The previous slide, I have emphasized the shorter overall treatment time and the optimal bone quantity. Now, what about the conditions for immediate implantation? The conditions are for the immediate implantation that neither periapical nor periodontal inflammation should exist. So the other important that the intact alveolar walls, only one wall is missing, the other walls should be intact. The other will be the minimum of 3 millimeter of extra-alveolar intact bone for the primary stability. Then the condition belongs to the condition, the automatic extraction in the atraumatic tooth removal, and also the very thorough cleaning of the socket. Then in the different biotype, gingival biotype, it seems to be the thick flat seems to be more suitable for the immediate implantation. So I would like just to show a picture. In the aesthetic zone, the tooth extraction always be performed using a flapless approach. In the picture, you see the very careful extraction and then the placement of the implant. The immediate implantation will provide a suitable substitute structure. There are clinical situations when we need bone substitution. If the space between the implant and the bone is less than 2 millimeters, then completely bony healing can be accepted if the mucosa is properly adapted by some authors. But the gap between the implant and the labial bone is 2 millimeters or more. These are also a clinical situation when we need a bone substitution. Usually, the need for bone substitution if the labial bone is thin or missing. And then the forming the alveolar process by the grafting procedure is also an option, a surgical option. And a 2-layer of collagen membrane, a BioGuide, recommended by Professor Buser. We have used bioxenogenic hydroxylapatite and slow resorbable BioGuide collagen membrane. We have used also that it is a very high success rate, and even if the slow resorbable collagen membrane proved a very good result. The sandwich technique we call, if if accidentally exposed implant surface, then when an autogenous bone, chips, or some specimens will be placed on the surface of the implant, then xenograft over that, and then just the resorbable membrane over it. This is a 3-layer of material. We call it the sandwich technique. I would like just to show you a case report, an unpreservable upper premolar tooth. The first step was the careful removal of the tooth, and just the examination of the sockets, to examine where can we achieve a primary stability. Then the placement of the implant, achieving a primary stability. And also will the sandwich technique, the covering the surface of the implant with bone chips. In this case, the bone chips are the fractured pieces of the labial bone wall. Then the placement of the bone substitutes and the membrane, and also then a very meticulous tensile suturing and an X-ray control. And the implant after the osseointegration, after the healing time, is ready for completing a crown. So, dear colleague, the next surgical stage of the completing aesthetic implant restoration is a very important, the soft tissue management. Then usually we call this the so-called two-stage surgery. Well, when we have a possibility and the overlying keratinized gingiva, just to form the gingiva around the implant and just achieving a proper aesthetic result. So then if this table, you can see the types of the second stage surgery. If there is sufficient quantity and quality of the gingiva, then a simple excision of the gingiva. Then the simple excision of the gingiva means just we excise the overlaying soft tissue, then the placement we remove the covering tissue, and just the placement on the transmucosal abutment. So the selection of the transmucosal abutment is then essential for the forthcoming procedures. Usually then the width should correspond to the subsequent crown and the other prosthetic options, and the height, it should be minimum 1 millimeter above the level of the gum. So, and you see then the simple excision that approximately that 6 to 8 weeks to be achieve a complete healing. But in this case, you can also see that at the gingival form, at the neighboring teeth, at the cervical portion, it differs from that of the implant placement. Of course, in the high smile line, it is always visible. And just at the first glance, one can see it as artificial teeth placed. Then, what can we do? Then the very simple surgical the procedure, the apically positioned flap. Now, the apically positioned flap is taken from the periodontology, and just is widely used although the implant dentistry as well. So the schematic illustration on the pictures means just an incision on the crest, just the labial direction over the periosteum, we shall make a flap, and just this flap will be rolled up in the apical direction and fixing by the transmucosal screw and suturing. You can see the schematic illustration of the flap reposition on this picture. So then, of course, we can change even the diameter and the length of the transmucosal screw. And just for instance, you see the special case when we wanted just to form the gingiva according to the neighboring gingiva form, and just after we can achieve a very good result with the temporary crown. The temporary crown may form the gingiva even in the next slide. I will just show to you even the papilla, but must be left inside for at least 2 to 3 months. So, dear colleague, the major issue is the missing papilla. The missing papilla from the aesthetically can be an aesthetically problem. So, in the following case, you can see it seems to be a perfect gingival seal, but still, after the placement and the abutment and the completing the crown, then is a so-called black triangle. The black triangle may appear. This one just is missing of the papilla, not the correct form of the papilla, means just the black triangle, which is in particular a high smile and aesthetically not pleasing. So we even in the dental lab can be correcting. The dental technician may form not a contact point but a contact surface, but it just then gives us problem in the hygienic access. So it's better in these cases just trying just to form the papilla and back the papilla again. So, namely, in these cases, when the implant are very close to each other, then also we result in a missing papilla. The form of the papilla is determined by the underlying bony septum, which often resorbs. And then on a dental X-ray with parallel technique, the possible development of a papilla can be foreseen. But in the case of 5 mm or more, the distance between the peak of the septum and the contact point of the crowns, the development of the papilla is uncertain. So, the illustration of the possible development of papilla in different solutions you can see on the picture. So, if this 5 mm is the key, and if it's the 5 mm and less, this from the contact point to the bony septum, is then the development of papilla is uncertain. The types of the second texture, the next one will be, of course, the papilla reconstruction technique, surgical technique. There are several surgical techniques, which has most of them are small pedicle flaps. Perhaps the well-known technique from Patrick Palacci, the flaps are turned and fixed interdentally. And you see that if that is the fixation of the papilla, and just these small pedicle flaps will form a papilla-like soft tissue formation. The split finger technique is also an interesting technique, which is also using small pedicle flaps. You see the small pedicle flaps. These pedicle flaps are rolled up in the apical direction, and the next one it will be split and pushing medially and distally and fixing by sutures. So, but we have to say that these small flaps, the different flaps, the different small flaps, using suturing may result in an impaired blood supply and possible to a necrosis. It can be a warning that too complicated little mucogingival surgical intervention. That's why it is recommended that the small intervention, the small gingiva forming, as this, for instance, the simple T-flap. You see then the T-form on the picture, and just we don't need any suturing. Just the so-called H, the letter H form flap, which means that both sides should be the mucosa then rolled up by a certain mucosa forming screw, abutment, and just it also may give a papilla formation. It can illustrate on this picture the half-form flaps for reconstruction, and then you see that one implant and two implant we can do it. It is very easy, relatively easy, and the suturing can be avoided. I just want to show a case also at a lateral incisor. It is a continuous periapical inflammation and periapical surgical interventions, and then no good result, and we have to decide that to just extract the tooth and immediately place an implant. You can be very simple solution. You can see the healed implant and just overlay gingiva. And in this case, we have to use a H flap then incision. You can see on the picture the age letter form, and just a special form of the gingiva forma may press up, may roll up mesially the mucosa, and just giving a papilla-like soft tissue formation. Then, of course, the abutment has been placed, and just the crown completed. So this can be a situation when the insufficient quantity and quality of the gingiva. It also can be used different method, but the most widely known is the so-called connective tissue graft. There's the free connective tissue transplantation. It can be the solution. Then in these cases, the pocketing over the periosteum, then the graft pulled into the pocket by a resorbable suture, and then closing the wound. It looks like an easy surgical one. For the patient, it's sometimes not so easy. Then just the graft is taken for the hard palate, where are the healing, it's relative slow, and can be also the healing can be painful to the patient. But it is a graft which is taken from the hard palate, is just pulled into the gingival pocket and suturing. The healing time is minimum 6, but then better than 8 weeks. So then the result you can see as before connected and after the connected the picture, and just we can complete the crown. Now, then what about the less traumatic options? It just free the mucosal, the connective tissue graft is not an easy surgery. And what about the less traumatic option? There are less traumatic options using synthetic collagen matrix. Then there are several products on the market. I just want to show you one. This is the O6 Volumax. Is a cross-link ossifying collagen, bone volume forming scaffold from GBR and the GTR. And then this can be wetted, give this saline solution. It is hydrated and just can be folded. Then dependent on the situation, we want just to fill up. And then you see that the next picture, it will be placed in the pocket, in the gingival pocket, and the healing time after the healing time is after 4 months. You can see that illustration how the healing is complete, and is the situation, and the gingiva is ready for completing prosthesis. So, dear colleague, some word I would just wanted to say to you something about the prosthodontics. The prosthodontic is a different chapter, but still, as a surgical procedure, we have to molding the gingiva for the natural emergence profile. How to form the gingiva, creating the emergent profile of the certain for the the front tooth. It can be different, the central, the lateral, inside, and the canine. So the steps are just formed as the emergence profile formation process, the selected healing abutment according to the diameter and the height. And just after that, the provisional crown restoration, the screw-retained provisional crown, which in the dental lab can be formed then corresponding to the neighboring teeth and just in the similar to that of the emergence profile of the neighboring teeth. Then the next step will be that fabricate the individualized impression coping. I will just then show you some more slides about that. And just finally, we have to select the final abutment. Now let's see the fabrication, the individualized impression coping. Then the next picture that shortly I can show you how can be fabricated. The first thing we'll be taking the impression about the crown and the labor analog, and just will be make an impression, and then after the impression coping will be connected to the labor analog, and according to the gap after the filling out, after the gap, we had filled out with self-curing acrylic resin, and we have to then finally a special impression coping, an exact replica of the emergence profile. Then we can take the impression, and after the impression, the dental lab, we can make, the dental laboratory can make the final abutment. The final abutment can be a different form, but the best form, particularly with the emergence profile, the high aesthetic result, if the proper anatomic abutment. The proper anatomic abutment follows the gingival margin. That can be titanium or it can be zirconia as well. We have to mention that even in the case of the thin gingiva, the titanium abutment may appear dark. The translucency of the thin gingiva may result in the different darkness of the gum according to the color of the titanium. That's why it's recommended a zirconia abutment and also with zirconia crowns. Now, as the materials are concerned, the selection of the aesthetic room material widely used, the PFM, the porcelain fused to metal, very popular material, economical. It has impaired aesthetic in some situation, and also may fracture. The most widely used, I think so, in aesthetic cases is a porcelain fused to zirconia, in the highly aesthetic. But the complicated, they consist of the CAD/CAM process, but still the aesthetic result will be the best. And that finally, I want just to thank you for the very honoring attention. Bye.